All right, welcome everyone. Thanks for joining us here today. Celebrating Mothers for Mothers Postpartum Justice's Nourish program with this monthly webinar that takes place. So it's such an honor to be here. And just to kick it off, starting off with some postpartum justice acknowledgement. So postpartum justice is a set of values forming the foundation of postpartum care that is fair and equitable. It is free of sexism, racism, and a healthcare system that is based on profit. Postpartum justice recognizes society's collective responsibility for all folks caring for new humans. It distills the postpartum wisdom from the past and transforms it to serve the future. So postpartum justice is a growing framework of values, and since 2019, it has been acknowledged with a day of celebration, both in Oakland and Berkeley. So mark your calendars. Every year it happens on the third Sunday of the month of May. And let's together celebrate this important time period that often doesn't get that acknowledgement in a day, but mostly in our day-to-day activities where we have over time created silos in the resources available to individuals during this period, which needs a village, needs community. So here we are at Mothers for Mothers Postpartum Justice. We are 24/7 caring for and sharing community through postpartum recipes and traditions, sharing realities that exist in our communities, and centering those that are Black and Indigenous. And so I'm Mara Gebre, and I'm a midwife in San Francisco. And I've been honored to start this partnership with Mothers for Mothers Postpartum Justice through community work and serving families through a collaboration through One Love Black community in San Francisco, showing up for families, and with the Nourish part of this program to serve meals to families in the community for 6 weeks. Mothers for Mothers Postpartum Justice has now served over 2,000 meals. Like, wow. And through different programs. And so it's just been an honor to see the grassroots collaborative efforts and crowdsourcing to raise the funds, to partner with restaurants to make postpartum centric nutritious meals that folks can have access to on a weekly basis. It's been beautiful and amazing. So I'm honored to be a board member. And I would like to introduce us to another board member who's here to share with us the urgency of expanding postpartum Medicaid coverage, Dr. Monica McLemore. At the University of California, San Francisco, Dr. Monica McLemore is a tenured associate professor in the Family Health Care Nursing Department, an affiliated scientist with Advancing New Standards in Reproductive Health, and a member of the Bixby Center for Global Reproductive Health. She retired from clinical practice as a public health and staff nurse after a 28-year clinical nursing career. Her program of research is focused on understanding reproductive health and justice. To date, she has 68 peer-reviewed articles, open eds and commentaries, and her research has been cited in the Huffington Post, Lavender Health, 3 amicus briefs to the Supreme Court of the United States, and 2 National Academies of Science, Engineering, and Medicine reports, and a data visualization project entitled How to Fix Maternal Mortality. The first step is to stop blaming women. That was published in 2019, Future of Medicine edition of Scientific American. Her work has appeared in publications such as Dame Magazine, Politico, ProPublica, and PR, and she made a voice appearance in Terrence Nance's HBO series, Random Acts of Flyness. She's a recipient of numerous awards and currently serves as a chair-elect for Sexual and Reproductive Health section of the American Public Health Association. She was inducted as a fellow of the American Academy of Nursing in 2019. And without further ado, I would like to welcome Dr. Monica McLemore, who will lead us in this necessary conversation and exposing the important needs of postpartum Medicaid coverage.
Thank you, Asmara. And I just have to say, full disclosure, I am lucky enough to learn from Asmara and her incredible work that she's doing as a Watson Scholar at UCSF. I also have to just thank the Mothers for Mothers Postpartum group. I met Marilyn Wong. It was alumni weekend at UCSF, and I had to give a 5-minute lightning talk. And it was, sort of right after the ProPublica, Terrence Nance, all that stuff came out. And I really talked about why we needed to center reproductive justice. And she comes walking up to me. She's like, I need you. And you're going to be on my board, and you're going to come guest lecture in my class, and you're going to do these things. And I am grateful for the clinicians who are on the call. I'm grateful that she has taught me 2 really important lessons. The first is humility. When I first joined the Mothers to Mothers Postpartum group, I was like, oh, why don't we just set things up with like meal delivery and Grubhub and this and that? And boy, did folks school me around how unethical. Rapid solutions sometimes can be unethical, and that there was a better way to be able to get meals to people, and that smart people had been thinking about it for a while. So I actually feel very grateful to be here because, you, Linda Jones, Dominique, Jaisha Wren, y'all have schooled me in a way that if I can use whatever platform I have to amplify the important work that we're doing, I'm in service to you all. For the folks who are attending, thank you for being here. I have a couple of slides I want to get through. I have to tell you, my heart is full today. I'm coming from a dissertation defense, which is like the best thing that any academic person can actually participate in. So to Dr. Norlissa Cooper, my presentation is dedicated to you. I want to talk a little bit about, and I might be a little bit provocative, purposefully controversial, because I don't know that I would be myself if I didn't. So I have been spending a lot of time thinking about postpartum Medicaid. And as Asmara mentioned, I have had my research cited in National Academies of Science, Engineering, and Medicine, or NASEM. For those OG folks like me, we used to call that the Institute of Medicine. And I will be participating in another National Academies of Science, Engineering, and Medicine meeting on June 7th and June 8th. And it's really, how do we advance health equity by centering the voices of Black, Indigenous, Latinx people of color, to have a workshop around thinking about reductions in maternal morbidity and mortality. So, I as you push an entire field to try and get them to understand justice, I hope if nothing more, you get some ideas and some takeaways around how we all collectively can make this better. So with that, people who know me on this call, people who don't, I think it's odd that we start our discussions with patients thinking that the patient-reported clinical history is the gold standard in how we understand how to diagnose and treat and work through all of our algorithms to help them get to some point of homeostasis, and yet we never disclose that about ourselves. I think that that's just very strange. So for me, I will draw your attention to the bullet in the middle, because I was a preemie in 1969, and all the work that I do is personal. It is scientifically rigorous, as Dr. Karen Scott has taught me. It's culturally rigorous, but the truth of the matter is we can do better. Our preemie statistics today are no better than they were in 1969. And I will not leave this earth without ensuring that we can do this better and make sure that we are doing it better. At the same time, you already know I'm on the board of Mothers to Mothers Postpartum, and I feel that disclosure is important because they are doing incredible work, and we are learning together. And my engagement really is to amplify the important work that you're doing. And sometimes I do seed them with some ideas that I think about that aren't necessarily naive. So let's talk about postpartum culture. I really want to put this out there that we talk a lot about death and dying when we give talks like this and presentations. Everyone knows this, right? We've done a really good job in educating the public around Black women are 3 to 4 times more likely to die in pregnancy and childbirth, blah, blah, like all that, right? We've done that. But what we don't pay enough attention to, and actually let me go back one, because even on the slide, the way that I've put it forward, I still didn't do a good job of like really getting at this 3 in 5 pregnancy related deaths could be prevented. That's what's circled here. That's why when I did my piece for Scientific American, I would not, and in fact, what's so fascinating and interesting about this piece is they're re-releasing it because they're going to have a whole issue on structural racism in healthcare. And they gave me a chance to update this piece. But what I really want to bring home is I fought to have this panel in the data visualization. They originally wanted me to talk about the root causes of maternal morbidity and mortality. And I said, I can't put my name on just death and dying. Not when we know the truth of the matter is most maternal deaths are preventable, right? Most 3 out of 5, that's more than half, right? I mean, so when we start to think about, and the numbers have actually been estimated from the Centers for Disease Control and Prevention, that is closer to maybe 60 to 70% if you look at the main causes of maternal deaths in the United States. There were spatial and temporal places, so in space and time, when we go back and review those deaths, that there were many places where people could have acted. There were places where we missed signs and symptoms of deterioration, right? So I'm really wanting to push us to think differently about this phenomenon and why the postpartum period is so important. You know, this is a slide I got from Marilyn, and I have to say, like death, avoiding death's not the best we can get, right? I mean, we have all these near misses. We have the collective trauma we've all been through in the last year, right? Avoiding death isn't like that should be the floor, not the ceiling. Right? We are talking about the propagation of the human species. People tell me that this is one of the most fulfilling things you can do in your life. I've never been pregnant, so I just take people's word for it, right? But to procreate and to have the courage to make the commitment that you want to shepherd another human through the different phases of this thing we call life is like a big deal, right? So this whole like not dying, that's the floor, not the ceiling. I don't have to tell folks on this call, maybe if I do, you know, and I know it's being streamed to YouTube, maybe folks don't understand. I actually am really starting to think we don't have a US healthcare system. We have systems. That's why I put the S on the end, because we have one system for people who have money. We have one system for people who are on public insurance. We have one system for people who live in states that actually think healthcare is a right. You have a whole other system for people where you don't, right? It's unequal. It's not prevention oriented. It's cavalier. I mean, I am really embarrassed that I've been a nurse since 1993, and we still do not have comprehensive paid family leave or robust postpartum care. Right? We have to make this different. I didn't tell people in advance at the start of this, but you have my consent, my affirmative consent. Screenshot, tweet, use social media. These slides are not proprietary. And so please, if you can use your channels to amplify these messages, I think we can create a collective understanding that postpartum people deserve better and that we can actually build better for them. I'm a public health trained person. And I have to say, you know, I do have to admit, I'm actually really not clinically retired. I mean, I have been doing flu shot clinics and doing COVID-19 vaccinations because I think that's really important. But again, those are preventative measures, right? 3%, like I do all that work as a volunteer. And it's really important that I do that work because we need robust public health infrastructure, but we were never going to get it when only 3% of healthcare expenditures in the United States go toward public health and prevention. We're not going to get there, y'all. And so at some point as citizens, we have to like demand that the three levers of finances in our country, the federal government, the private sector, and philanthropy, all decide that postpartum people are like the low-hanging fruit of the investments that we should be making to improve health, right? I want to clarify any confusion that people have around the drivers for why we see maternal morbidity and mortality, because I'm starting to see this resurgence of older and sicker and fatter and all these blame narratives. You know, we're starting to also see this in vaccination and masking versus not, and I'm like really over it. So I'm going to show you a picture. Everybody and their mother always asks me where I get the slide from. I got it from Dr. Joy Creer-Perry, who got it from this book. So this is the actual reference for the picture I'm about to show you. This is how I think we really get to this notion of why we have differences in the distribution of disease, the differences in distribution of illness, and the differences in distribution of well-being. There are differences, in my opinion, because of policy decisions that we make. So if you look, a lot of people have started to understand what social determinants of health are. And when you look at that tier, you know, these are like basic things that all humans need to exist, right? I hate the way people talk about social determinants of health because it's like they got plucked out of thin air from somewhere. Like you have a bad transportation or redlining or whatever, like that came from nowhere. Actually, that came from up here, right? When you have power and wealth imbalances, which really comes from institutional and structural racism, class oppression, and gender oppression. That's where these things come from. We make these policy decisions, you know, around how we want to distribute resources among and between populations, right? If that wasn't true, then we wouldn't have over 500 bills trying to ban abortion and all sorts of other reproductive rights. And you wouldn't have voter suppression, because then there's a fear that these things, these kind of policy decisions that we make might change. And so as we start to like talk about the social determinants of health, or when we think about transportation, or when we think about postpartum meals, or when we even just the availability of food, let's act like that doesn't, like that's plucked from thin air. It actually comes from different kinds of decisions that we make. One thing that I think is apparent, and we're starting to see quite a bit of, is there's no collective narrative around postpartum care. Like nobody actually really owns it as a domain where we can have some accountability, right? Like we know on the pediatrician side, we want readiness for school and for children to receive their vaccinations and that they're meeting their developmental guidelines. And kind of on the OB side or on the sort of pregnant person side, we want to make sure that their body is healing normally. But like nobody actually really owns postpartum, like period and work. There's been a good amount of attention where people have tried to look at it as like the fourth trimester, but there are no structural pieces that really get at the postpartum period, right? And here's a perfect example of that, right? I saw the Red Table talk that Jada Pinkett Smith does with her mom and her daughter that Dr. Tressie McMillan Cottom was on, who told her horrific story that she outlined in her incredible book, Thick, around how she lost her insurance coverage because after she lost her daughter, who died, that she was carrying in her doctor's waiting room. She was no longer considered a pregnant person. And so because she was no longer considered a pregnant person, all the coverage that would have gone along with the pregnancy global benefit didn't apply because she was no longer pregnant. Like that's a pilot. We could fix that, right? That's not impossible. Just to say that regardless of how any pregnancy ends, we will extend coverage for a year. That's not, we could do that right now and really help infertile people and really help people who have pregnancy loss and actually help people who have abortions, right? We actually could do that now. One problem I also think that our system is really geared towards individualism, and insurance coverage dictates so much what happens in our country as well. and that the differences that you see among and between what people have access to in the postpartum period is also grounded in this individualism. You're lucky if you have social support. You're lucky if there is another adult involved in the pregnancy, whether that's a spouse or that's a man who, is involved, or a father, or however you want to talk about the constellation of people around a pregnant person. We don't have sort of infrastructure or policies that support that. We actually could make that happen. We could actually make that a thing. I think, I've talked about patriarchy, but one of the other things that we need to talk about is sexism. And what I mean by that is the purposive distribution of resources or withholding of resources because of one's sex. And I'm using that word specifically because there's a whole different set of biases when it comes to gender. But what I'm talking about is everything from these structures that we put in place for pregnant capable people that cut out everybody else, right? We don't have rest. People are considered non-essential. I have conducted qualitative interviews where pregnant and postpartum people have had to go back to work, 8 to 10 days after birth because they need to generate income. Like it actually really doesn't have to be like this. And if the last year hadn't taught us anything, it's just we had an opportunity for a natural experiment around paid family leave because we had a national shutdown. Right? We had a real opportunity to take advantage and just say, you know what? Because of the Patient Protection and Affordable Care Act, we're going to push money out to everybody who are pregnant capable, and we are going to make sure that you maintain your insurance coverage. We're going to make sure that if you're an essential worker, you will have a place to quarantine, you will have access to PPE, you will have all the things that you need. But everybody forgets that right after the election, the Supreme Court heard a case yet again challenging the insurance mandate of the Affordable Care Act. We were waiting to hear that decision any day. People forget that, right? So as we start these are policy decisions, elections matter. So as you start to really think through where these social determinants come from, this is why I think we need to really start paying attention to the policies and not just the politics that lead to the distribution of human and money and time resources. Before I die, I'm doing something about this. I am completely over the sex and gender pay gap. I'm over it in ways that I can't even describe. And this graphic, I chose this specifically because for people who know these numbers, white women make 79 cents to a white man's dollar. For Black women, it's 69 cents. For Latinx people, it's 55 cents, okay? Just to be really, really clear, right? If we just resolved or solved the Equal Pay Act for folks, we actually probably could see some health improvements, but we can't even do that. This whole loss of the workforce, everyone talks about how sad it was in December during the pandemic that almost 100% of the workplace losses from or departures from the workplace in the jobs report were women. What people don't tell you is almost 99% of those were Black and Latinx women who had caregiving responsibilities and homeschooling, and they left the job market. So all the gains that we have tried to operationalize over the last, 2 decades were completely eroded by COVID-19. Now we're back in a situation where we're looking at not good living wage paying jobs, but we're again looking at this overrepresentation of women / pregnant capable people in part-time positions. And everyone knows most part-time positions don't afford you what? Employer-sponsored health insurance, right? These are decisions. These are policy decisions that we can fix and change and remake. I'm gonna show this picture until the end of time. If we're not going to fund a social safety net, then we're going to see that lack of funding on our healthcare spending. Let me say that again, because people get confused about this. In countries that have robust social safety nets, generous benefits for family leave, readiness for school, child meals. Like if you have a robust social safety net, you are able to reduce your healthcare expenditures. Okay, that's the trade-off, right? Because we are humans. None of us are immortal. So you're gonna pay your money either on the front end or on the back end. And that's a decision. Keep coming back to these are decisions that we can be making differently. When I first saw the statistic, and this actually came out of the Bureau of Labor Statistics, and this is from 2019, not 2000, like not 1909. This is from 2019. Nearly 1 in 4 U.S. mothers are back at work within 2 weeks of childbirth. That's how much we respect pregnant, capable people. We don't even give them the reverence, the rest, the transition, right? The lactation support. How do I, return to my body? How can I become, a partner again? Lactation, my other children, right? This is who we are. So I'm hoping that we will choose to be different. I would be remiss if I didn't say anything about the erasure of traditional postpartum period wisdom, midwives, doulas, birth workers. This picture, in my opinion, captures the fact that medicalization has not brought us better, right? It just has not. And at some point, we are going to have to really start thinking again about what are those traditional, trusted processes when we think about birth as a normal physiological process. Where are the repositories and the holders of wisdom? And I think we really, really need to reframe our attention to those practices, to those individuals, to those communities. I have a huge place in my heart for grand midwives, for people who don't really understand. And I think Mama Shafia Monroe has been doing this incredible job. I know Khalees has been doing this as well on her Instagram of really sharing like traditionally lost postpartum recipes. What helps with lactation? What helps with uterine involution? What really helps with to keep your energy up? Man, you're feeding yourself and a whole other person, right? They have been doing amazing direct to the public education about the kinds of meals, about the times of meals, about the mixing of different food groups to ensure that lactating and postpartum individuals can have optimum health while also ensuring optimum recovery, right? I am so over the surgical textbooks and all the other books that our learners are required to read. And we're not asking faculty who are watching this or people who teach students, or if you teach doulas or whatever, we need to widen our aperture of the literature that we ask our learners to read so that we can have a conversant discussion about how communities can pull in all the different resources so that we can optimize not just an individual's health, but a community's health. There are 7 traditional wisdoms from postpartum. This does not come from me. It comes from a mashup of all of the books that I just showed. It also comes from, wisdom grounded in reproductive justice. It also comes from a global perspective of understanding that the experience of birth and parenting and family is actually situated in our ability to support pregnant, capable people. One thing I think that gets really, really lost is number one. I mean, I've been doing a lot of qualitative research recently around COVID-19 and pregnancy, and I have to tell you that families were really left high and dry. I mean, they didn't know when it was baptism okay? When can I come back into society? When can I take the baby out? When can they go see their grandparents? When can auntie, like there were all these questions around pregnancy and COVID-19. And I think we owe a huge apology as well as some reparations to the people who birthed during the pandemic, because that was one of the most inhumane things I have witnessed, not only as a researcher, but also as a human on this planet. And that folks had the courage to propagate our species when we were losing hundreds of thousands of people a day around the world. We have to like stop or pause and just like acknowledge that, right? I mean, it is huge to think that after the year that we've been through, that we are actually going to think about looking at, birthing outcomes, maternal child outcomes, reproductive health outcomes, without acknowledging collective trauma and controlling for it in our research. I actually really think we're going to be doing a huge scientific disservice. So the data visualization project I did in Scientific American was not the only piece I did in Scientific American. In fact, at the height of the pandemic, I wrote a piece that I stand by every word today, which is that COVID-19 was no reason to abandon pregnant people, because Governor Cuomo thought it was a good idea to ban accompaniment of whether it was doulas or spouses or family members or whatever from birth sites in New York City. I wrote that piece on March 26th of 2020. I stand by every word today, because if there was anybody that needed to be protected during a pandemic outside of healthcare workers, it was pregnant people. And I like to remind people that prior to the pandemic, pregnancy is the number one reason why people are admitted to hospitals and healthcare institutions. Childbirth is the number one reason, of almost 4 million births a year. So if, volume and frequency aren't enough for us to reimagine how we think about pregnancy and postpartum care, I don't know what else is. And the third piece that I wrote, I brought in, this is an intergenerational piece of scholars, clinicians, nurses, midwives, policy folks, and even a founding mother of reproductive justice, because of a tweet. So for people who don't use social media, I highly suggest that maybe you rethink that option, because most of the media and press I receive come from my social media posts. So I thought it was great when the American College of Obstetrics and Gynecology backed one portion of the American Rescue Plan, which looked to extend postpartum Medicaid for a year as part of the American Rescue Plan or the COVID-19 package. But what it didn't say is, number one, the federal match was not mandatory. It was voluntary. It didn't force states that didn't expand Medicaid under the Patient Protection and Affordable Care Act. It didn't force them to expand Medicaid, even to pregnant people. So we have to use the different tools at our disposals to talk to the right people so that we can get changes in policy, so that we can actually start to see some investments and some improvements in how we think about the postpartum period. And the low-hanging fruit here is, if we know that postpartum Medicaid or postpartum insurance coverage is associated with better outcomes, whether it's people get their glasses and go to the dentist and make sure that they don't have, sub-infectious rates of sepsis because they haven't had dental caries taken care of, all the way through, we can get hypertension under control, and we can get diabetes under control in that time period, so that pregnant, capable person is healthy regardless of if they decide they want to parent another child or birth another child. That's a payment and an investment that we're making if we don't have a social safety net. Dr. Toni Bond, who is the founding mother of RJ, that I'm happy to be supporting her postdoctoral work, wrote this top bullet. I'm gonna read it aloud because it's one of the most important things that I'm glad was in our piece. Medicaid expansion is an ethical imperative and a moral duty of federal and state governments to protect the health and welfare of the most vulnerable populations in our society. right? We use our military force and the military budget as a public good because that is to protect us. I would argue on the health services side that we need protection. So as we start to really think about this language or this discourse that we use, we accept our need for military as a public good for protection. I would argue that we need insurance coverage for our citizens as protection. I think it's still, we need to start calling out, and I've been doing this for almost, I don't know how many years, what, a decade since the ACA has been around. Those 12 states that still continue to deny insurance coverage under Medicaid expansion, all them people need to be called out. Because how you can rationalize that after a global pandemic, I'm waiting to hear that argument. I think we need to be bolder in our approach in terms of how we call these things out. We need to use words like shameful, embarrassing, unethical, because in my mind, that's exactly what it is. How do we do this well? Not to toot our own horn, but I started this discussion around my own arrogance, thinking that we could just contract with Instacart and Grubhub and think that that would be acceptable. And I was really grateful that the board, they called me in and was like, no, actually, that's not the way to do this, Monica. And what they really put forward, and I think Asmara started to read out what postpartum justice is, but this is how I think about it. It is a set of values forming the foundation of postpartum care that is fair and equitable, free from sexism, racism, gender oppression, patriarchy, right? And a healthcare system that's based on profit, right? We don't make the military turn a profit, and yet they're still supposed to be protecting us. Like I need us to start making those kind of metaphors, even for, the sort of abolitionist folks. Those are arguments we could be making around where we make our policy investments. Postpartum justice recognizes society's collective responsibility for all parents of new babies. I am the aunt of the year. Okay, I have babies all over the world, never birthed in my entire life, because I take my job as a member of the village seriously. And I know there's a lot of other people who do, right? The grandmas, the aunties, the gay uncles, the gunkles, like everybody, right? People take this seriously. And we're not going to transform our future if we don't start to really acknowledge postpartum justice as an essential component of reproductive justice. I was at this summit, and I have to tell you, it was one of the most transformative days of my life. And not just because it was one of those weird, beautiful, sunny days in San Francisco. It wasn't foggy, it was warm. But that our hosts, how it opened with music, how we were in the Museum of the African Diaspora, which is one of the most beautiful and best museums, I think, in San Francisco. How we were able to have intergenerational discussions and conversations. How we heard from doulas and midwives and journalists and physicians and nurses and community members with lived experience and policy folks. And it just was such a beautiful convening, and gave me and chefs, right? It gave me a real window into how all of this could be different. Students, learners, elderly, right? That day was transformative for me in a lot of ways. And part of what it also taught me was that we could completely disrupt discussions that have exclusively been talked about in a clinical domain. I said this earlier today, I'll say it again. Birth is episodic. It's an episode that happens in a place. Pregnancy happens everywhere, right? And we need to start thinking about it in that way. Because if we continue to focus in on the episodic, then we miss all these other opportunities to be innovative in how we want to think about the transformation of care for pregnant, capable people in our country. The Nourish program has blown me away, and I'm glad that people, for the clinicians on the call, if you could just continue to be humble and listen to folks. I will never forget when Master Doula, Linda Jones, just pulled me in and was like, "Nah, Monica, we ain't doing that." And when you're in community with people and you have respect for folks, and I just can't, I will never be able to describe my relationship with Linda Jones, except for sheer love, adoration, and respect. But when she pulled me aside and said, "You need to be quiet and listen," that's exactly what I did. Because not only do I trust her, I know she is wise in ways that I am not. And Nourish has completely blown me away in the ways in which it wasn't even just getting meals to people, it was the ethical process through which it was done. It taught me a huge lesson. So if my, journey to humility is any help to any other clinicians, you can admit when you screwed up on a national webinar. And you can also show people how you learned from that and to model that behavior. Because I'll tell you, the Nourish team has done an incredible job with everybody listed on this slide. And it is a model I think not only should be replicated, but I think it should become the standard for postpartum people. I want to thank everybody for being here. I want to thank you for listening. I want to engage. I see the chat. Of course, my dog now has decided she got to wake up because that's who she is. But I wanted to leave enough time to really be able to answer your questions, to engage with this content. And I hope what I've done is really given you some language to think a little bit differently in all your different circles where you are, right? I actually operationalized the retrofit, reform, and reimagine framework I've been talking about a lot on social media, because I'm sure people who do not feel comfortable with war will probably feel a little strange retrofitting that public good argument that we invested in and it doesn't have to make a profit towards the protection that postpartum people need. But you can be on Team Reimagine and keep thinking about how can we build Nourish 2.0, right? You don't have to take every piece of what I said and think that that's your space to operationalize doing it. Because if all of us are retrofitting, reforming, and reimagining at the same time, then I think we will penultimately get to what we really want, which is postpartum justice. So with that, it takes a village. I love these images, obviously, which is why I put it, in my presentation. And this is the contact information. I'm sure it'll be shared again, but I can't, lift up enough. This model is actually the way we should be going. And I think it builds on some important programs that I, as a nurse, have been fortunate to work on. And I couldn't even see it, right? When I think about it, it's like, oh, it's like school lunch program plus Meals on Wheels, but like really, really reverent around birthing people. Like it actually makes sense. And to get out of my own way to be able to see it. And so if you have courageous people in your circle who are willing to call you in, please listen to them. Because that's where we get our innovation. That's where we get our change. That's where we get our amplification. And that's how we make this all different. So with that, I'm stop sharing my screen because I see all sorts of chat blowing up. I need that, right? Let's see. And